I'm Mark Sobel. I'm Executive Officer of the American Society for Investigative Pathology. My initial comments are supported by our policy, which have also been endorsed by several members of the Pathology Roundtable, including the American Society for Clinical Pathology and the Association of Clinical Laboratory Physicians. I think Les and Alexis have both presented the same thing that we would say in general, but I think our unique expertise and area of experience is related to the research laboratory that is not CLIA certified. The vast bulk of research laboratories are not CLIA certified, and they are not run by MDs. They are run by people that are not in the clinical sphere. So I'd like to make a few points based on all the comments that have been made earlier today. The first observation, which Susan Wolf made in the last panel, was that the vast majority of examples that have been discussed today are genomic research. This is just the tip of the iceberg of all the types of research that are done. But I would hazard to say, and Les alluded to this, that if we are going to develop an infrastructure for figuring out how results of individual research can be conveyed, that an easy way to start would be with the genomic type of research, because that is the most currently easily validated type work. That doesn't mean to say that all the other research is not valuable. Another comment would be made about the great variability in the types of research that's done. A lot of research we've talked about today, we've alluded to the fact that a lot of research in research labs are discovery-based. They are looking at signal transduction pathways. They are looking at mechanisms. They are not designed to provide results about individual samples. A lot of this work is, of course, biospecimen based. So I think we have to realize that the vast majority of research is not genomic. It could be proteomic. It could be the other omics. And it is really not designed, even when using human specimens, to have a plan to return research results. And I think that's a critical thing that's come up at various times today. So we need to really think about the types of specimens that are used. Carolyn Compton this morning pointed out the variability in analytes, things that we didn't even think about 20 years ago that we now know have enough biospecimen research to know that these are factors that affect the results when you're using different types of specimens. How long were they sitting on the lab bench? At what temperature? How were they stored? What was the status of the patient when the specimen was obtained? Was it under anesthesia? Did they just have caffeine, which can affect biochemical pathways? These are all variables that we have to be aware of. And most researchers, let alone clinicians, are totally unaware of all these variables. And so we have a huge gap to cover in terms of education and knowledge. So one of the major important ways of thinking about an infrastructure is to increase resources that would educate not only research subjects, but also researchers and clinicians about this variability. We've also talked about the lack of research rigor and reproducibility, and I don't want to throw my research colleagues under the bus. I think this has to be put in perspective. We often quote to alert everybody about the dangers of just assuming research is all valid, that around 70 to 80% of research is not reproducible. That doesn't mean fraud. That doesn't mean poor performance. A lot of this has been shown to be lack of providing insufficient methodology. A lot of this comes from 20 years ago when research publications limited the methodology sections of articles and forced people to either delete them, refer to old studies, or put them in supplemental information. And so a lot of this is just the information is not available, but could be reproduced should such information be produced. We also know now much more about the types of analytes that are used. Researchers in good faith get 3 different sources of antibody to do an immunohistochemical study, not realizing that although they are different lot numbers and they are labeled differently and coming from different companies, that they're actually all made from the same original supplier. So they're actually using the same antibody 3 times, not realizing it. And this is a big gap in knowledge that we've just become more aware of in the last couple of years, as the NIH is now beginning to look more carefully at grant proposals and how people are addressing these issues of variability of analytes. So I think there's a long way to go, and that's another major area of education that needs to be addressed. The other point that's been made today is that there are clear differences between research laboratories and CLIA-certified laboratories, and for that matter, clinical laboratories. And they all serve different purposes, and trying to make them all fit into one mold will actually probably disadvantage all progress in all these areas. So we need to respect the value of the research laboratory that is not CLIA certified, the research that is done in CLIA certified labs, and the clinical labs. They all are addressing many, many critical areas, and working together we can all advance our knowledge, but we cannot fit them all into one mold.